So welcome everyone. I'll be talking about stroke imaging update. My name is Bhavya Rihani. I'm an assistant professor at Department of Radiology and Biomedical Imaging at University of California, San Francisco. I'm the president and co-founder of Health4TheWorld, which is an international nonprofit initiative. So welcome everyone. I'll be talking about stroke imaging update. My name is Bhavya Rihani. I'm an assistant professor at Department of Radiology and Biomedical Imaging at University of California, San Francisco. I'm the president and co-founder of Health4TheWorld, which is an international nonprofit initiative. So today we'll be talking about a few things. What are the recent updates in stroke imaging? What imaging tools should be used based on the recent evidence? And where are we heading in the future in stroke imaging? So let's talk about the recent updates in stroke imaging. I won't go through the trials, but I will just have a very practical perspective from a radiology resident or a radiologist perspective about what we should know about what is going on. So these are the new endovascular trials in stroke. And these are the late ischemic stroke trials. But what are we trying to do here? The recent trials have shown efficacy of adding endovascular therapy versus standard care in treating patients with acute anterior circulation stroke, even up to 24 hours after symptom onset. So this is an amazing breakthrough, because for a long time, we were only treating patients up to 4.5 to 6 hours. And now we can treat patients up to 24 hours after symptom onset, depending on imaging. So that is where the role of radiologist comes, because we can actually help in selection of the patients who will actually benefit from treatment. So what can we learn as radiologists from these stroke trials? So all the stroke trials used non-contrast CT and CT angiogram. And some of them used CT perfusion and some used MRI. So let's start with non-contrast CT. That is the first step in any stroke imaging protocol. So on the non-contrast CT as a radiologist, we generally have a 3-question approach. The first question is there intracranial hemorrhage or a large territory infarct? Second question, is there a hyperdense vessel? And third question, what is the aspect score? So the first question is intracranial hemorrhage. So this is a 60-year-old with sudden onset of left-sided weakness and headache. And we have a large right basal ganglia, thalamic and intraventricular hemorrhage with hydrocephalus. So this is a patient in which we cannot give IV TPA because this patient has a large bleed, likely due to hypertension, given the location. So the first step is always to check for hemorrhage. If there is no hemorrhage, we can proceed for the ischemic stroke protocol. The second question is there a hyperdense vessel? So for example here, this is a hyperdense basilar artery. So this is a non-contrast CT, which shows the hyperdense basilar. And on the CT angiogram, we can see the filling defect or the clot in the basilar artery. Now moving on to aspect score. So the aspect score is a total score of 10. There are 3 scores for the lentiform, internal capsule, and the insula, and 1 for caudate. So these are the 4 structures which get 1 score of each. And then there is M1, M2, M3, M4, M5, and M6. So subcortical structures are allotted 3 points, and the MCA cortex is allotted 7 points. To compute the aspects, 1 point is subtracted for 10 for any evidence of early ischemic change of the defined region. So the perfect score is 10. If we have the area involved, each area gets a score of 1. A normal CT scan means there's an aspects of 10. A score of 0 indicates diffuse involvement throughout the MCA territory. And aspects of 6 or 7 indicates moderate infarct, and more than 8 is a small infarct. So, it's important to know the aspects because, worldwide, this is an accepted notion, and it has been used in the trials. So let me just go to the next slide here. Okay, so for example, what is the aspect score in this patient? So a perfect score is 10. So how many structures are involved here? We have the insula involved here, and we have one of the M2 parts involved here. So we subtract 1 for insula and 1 for M2. So that would be 10 minus 2, and that would be 8. So this would classify as an aspect score of 8, which is still in the small infarct distribution. Okay, so we did the non-contrast CT, we assessed for hemorrhage, we assessed for a hyperdense vessel, and we calculated the aspect score. Different hospitals in US have different protocols. Some hospitals report the aspect score and report. Some hospitals do not report the aspect score. And the reason is because there is some inter-observer variability. So some radiologists might say it's 8 and some radiologists might say it's 9. So some people do not report it in the report. Okay, so now moving on to CT angiogram. So that's the second step. On CT angiogram, we have to look for proximal vessel occlusion. We have to look for how are the collaterals. And then sometimes you can actually see the infarct better on a CT angiogram. So first of all, is there a large vessel occlusion? So this patient has a right M1 clot. So we can see it right there. We can see the filling defect in the M1 on the right. And this is a collateral score system which has been developed at Massachusetts General Hospital. I did my fellowship there, and depending on your institution, you can employ the collateral score or not. The score of 0 means that there are absent collaterals. Some have also mentioned this as malignant collateral patterns, and these patients generally do not do that well. And then you can see the scoring improves if there are better collaterals from score 1 to score 4. There is also multiphasic collateral score, which has been developed in Canada, in which the CT is done in multiple phases. Sometimes the infarct is seen better on the CTA. So this is a CT image which actually shows the infarct, and this is a follow-up which shows the infarct. So the non-contrast CT was absolutely normal. And then on the CT angiogram, we could see that there is some hypoattenuation here, suggestive of the infarct. So if you don't see the infarct on the non-contrast CT, you can look at the CTA windows to see if you can see the infarct. So when I work with my residents, the most common question is, how do I know what is M1, M2, M3, and M4? And it becomes important if you have a neurointerventionalist at your hospital, because they will always ask you which segment of the middle cerebral artery has a clot. So this is what I tell them. This is the MCA, the first segment is the M1. This is the horizontal region. You can see that this is the axial on the coronal. You can see the M1 right there. When the MCA turns into the Sylvian fissure right there, it becomes M2. So before this, even if the MCA bifurcates here, it is still M1. As soon as it turns, it becomes M2. You can also pull up the coronal. So from the horizontal, it's becoming vertical now. So that is M2. And then M3 is again when it becomes horizontal and turns again. And M4 is the cortical branches. So this becomes really important because the question always is the clot in the M1 or the M2? So you have to just figure out whether the vessel has turned or not. If it hasn't turned and if it's still in the horizontal segment here, it is M1. All right, these are the branches of the segments of the ACA. A1 is before the ACOM, then we have the A2, and then we have the A3, A4, and A5. For the PCA, P1 is the proximal PCA, P2 is the segment within the ambient cistern, P3 is a quadrigeminal cistern, and P4 is a cortical region. Okay, so the segments are marked on the CTA here, P1, before the PCOM, P2, P3, and then P4. The most important thing which we have learned is we had a case in which, we looked at the axial CTA images and we did not see any clot. But it's always important to pull up the coronal MIPS or the coronal CTA image, because you can see the basilar tip clot best on the coronal. So sometimes on the axials, because of the volume averaging, you won't see the basilar clot that well, especially if it's a very small clot. So always pull up the coronal and check for a filling defect to look for a basilar clot. So generally when we do our stroke protocols here, we do a non-con CT, we do a CTA, and unless we get the coronal, we do not say that there is no clot, because you want to confirm on the coronal that there is no filling defect. All right, so we started with the non-con, moved on to the CTA. Next is, some of the trials used CT perfusion while others used MRI. So if you have a CT perfusion, the most common approach is a 3-question approach. How is the core? How is the penumbra? And what is the mismatch? So this is a table which we used back at Mass General, in which we actually could understand which stage is the tissue. So if you start from here, and so this is how the tissue starts when there is decreased blood supply, and this is how it proceeds. So in the beginning, when there is low blood flow, then there is preservation of the cerebral perfusion pressure. Then this is a compensated stage. This is the underperfused stage in which the tissue actually becomes dead. And then this is a post-ischemic hyperperfusion. So you do not have to know this table by heart. We used to have a printout and put it in the reading room. But the most important thing to understand is just the concept that depending on the stage of the ischemic tissue, you can get some variability in the CBV, CBF, MTT, and Tmax. So people think that in stroke, you cannot get increased CBV, or you cannot get decreased Tmax. But depending on the stage in which you capture the tissue, you will get variability of CBV, CBF, MTT, and Tmax. And usually when I report my perfusion, I always say there's a defect rather than saying increased or decreased CBV. And if you want to be very accurate, you can say increased or decreased, and you can even use this table and decide which stage the tissue is. It can be useful for neurologists for blood pressure monitoring, if it's underperfused versus overperfused tissue. But again, this can be useful clinically, but also conceptually, it's good to know that there is some variability depending on the stage of tissue. All right, so this patient, we can see the hyperdense M1, distal M1 here. So right on the CTA, we see the filling defect. We know it is M1 because the vessel hasn't turned yet. It turns right here. So the filling defect is before the turn. So this is a distal M1 clot. Here we can see that there's a mismatch between the MTT and CBV. The CBV does not show any defect, but the MTT shows a large defect. So there's a mismatch. So that means there is viable tissue. As compared to this patient, in which there's a large defect on CBV and a large defect on MTT, which suggests that there is no viable tissue, and this is just dead tissue. We just installed a rapid software for evaluation, for automatic calculations of the core and the penumbra. There are multiple other softwares available for automatic calculations. These can also be done just visually. We have been doing it just visually without any calculations for a long time. But since the new trials, especially for late stroke, especially if there's a neurointerventionist, the softwares can be used. Okay, so we talked about CT perfusion. The CT perfusion helps us analyze whether there is any viable tissue or not. Next, moving on to MR. So MR, we can have a 3-question approach. First is, how old and large is the infarct? Second is, which is a very important question, am I sure this is not a stroke mimic? Because you will see stroke mimics all the time. And you might be the first person to tell the neurologist or the neurosurgeon that, I don't think this is a stroke, this is something else. And the third is, can I apply newer imaging modalities for a better diagnosis? So the first question is, how old is the infarct? So this is how the infarct evolves. Hyperacute is less than 6 hours. Acute is 6 to 48 hours. Early subacute is 2 to 7 days. Late subacute is 1 to 4 weeks. And chronic is more than 4 weeks. So you can see that the early subacute starts at day 2. So subacute is a long time frame. It can be as early as 2 days to as late as 4 weeks. So this is how the MRI evolves in acute, subacute, and chronic. So in acute stage, the ADC is decreased. In the subacute stage, the ADC can be low, normal, or high. And on chronic stage, the apparent diffusion coefficient increases. The flare can be positive or negative in acute stage. It's usually positive in a subacute, and chronic, it's positive. The enhancement is not there in acute infarct. There is gyriform enhancement in subacute, and then chronic, there is laminar necrosis. So, so for example, if you see a gyriform enhancement in an infarct, you know it is subacute. Important learning point is that for a long time, radiologists believed that the flare only becomes positive in a subacute infarct. But recent literature has shown that flare can be positive as early as 2 hours. So if you see a flare positive infarct, that does not mean it's subacute. It could easily be acute. So it's important to remember the new literature for the flare positivity. All right. Sometimes we help the radiologists if they are interested in actually dating the infarct in days. And these are the 3 values which we use. A low ADC is usually less than 10 to 14 days. The pseudo-normalization occurs around 4 to 10 days. And the enhancement is 1 week. So if you see an enhancing infarct, you can tell the neurologist this infarct is at least 1 week old. So you can also go in days in dating the infarct and do a very good job if you use these 3 values. All right, so we talked about how old is the infarct. The next question is how large is the infarct? This becomes really important with the new literature which is coming in, because if you have a small infarct, that patient might benefit from endovascular treatment. So DWI more than 70 cc's is specific for poor outcome. And how do we calculate the DWI volume? It's very easy. It's the same way which we calculate intracranial hemorrhage volume. So it is the length by width by height divided by 2. So it's ABC divided by 2. So you can actually calculate. We used to do the calculation of the volume on the scanner in Boston when the patients came in and got a DWI. So it's very easy. You just need a calculator, and then you can do it manually too. All right, so there's a very important concept of CTA DWI mismatch. If the stroke patient ends up getting an MRI, and if this is what you see a proximal vessel occlusion, which is an M1 clot, and you see a small core or a dead tissue, then you automatically know that the remaining tissue is the penumbra. So the question which somebody might ask you as a radiologist is, why should I do MRI on stroke? It takes time, and you can just do a quick CT perfusion. But MRI is the most accurate way of looking at the core of the infarct. So if somebody is confused whether this patient is having a stroke or not, or how large is the infarct, the most important sequence is DWI. It will tell you exactly how much is the dead tissue. So for example, this is the area of the diffusion, and that is the only area of the dead tissue. All this area, which is normal, is not involved. So it's a most accurate way of looking at a stroke and looking at how large the stroke is. All right, and then different trials and use the volumetric assessment for stroke for measure depending on the core measurement. For example, this is a table from Dawn trial from last year. Okay, so then if you could figure out how old is the infarct and how large is the infarct, whether it is subacute, chronic, or acute. And then the next question is, can I apply neuroimaging modalities for a better diagnosis? So ASL is something very new, and I'll just show a few pictures of that because it's a very simple sequence which can be added to the scanners. I don't know if it's a G or Siemens scanner or other scanners you have, but it can be added. And it is very good because you do not need contrast. It is basically looking at the tissue perfusion without contrast. by magnetically tagging the water in flowing blood. So specifically in stroke, when you're like running around and you don't have time, ASL can be really good. So for example, this patient had water zone infarcts in the left cerebral hemisphere, had ICA occlusion. And then on the ASL, you can see that this whole area in the left cerebral hemisphere demonstrates decreased perfusion. So the DWI is the most accurate way to look at the core. So this tissue is dead. ASL will show you the decreased blood flow. So, and this area has decreased blood flow. So we know that the whole left cerebral hemisphere is not dead yet. So we know that there's a mismatch. So there is still some viable tissue. So ASL is a very quick sequence which can be added on the scanners without giving contrast. This is a case which I saw on call back at Mass General, and this shows the importance of something like ASL or perfusion. So this patient came with altered mental status, and nobody knew what was going on. And you can see that there is diffusion restriction throughout the right cerebral hemisphere. And what is striking is it's both in the anterior circulation and the posterior circulation. So it is ACA distribution, MCA, and the PCA distribution. So when you see such a widespread diffusion restriction, you think about seizures, you know? And so this is what the ASL showed. ASL showed increased blood flow in the hippocampus, suggesting that the hippocampus is on fire, is leading to the seizures. So it helped us make diagnosis that this patient does not have stroke. It's actually seizure. And that is why this patient has altered mental status. And that is why this patient has diffusion restriction and multiple vascular distribution, not just in ACA, MCA, but AC, MC, and PCA distribution. So seizures can cause diffusion restriction. So here, this is just a zoomed in picture of the diffusion restriction and increased blood flow on ASL. So ASL can be super helpful. The good thing is, if you don't have ASL, you can still make the diagnosis of seizures, because the seizure-related excitotoxic injury in the brain is transient. So all you have to do is you have to get the patient back after the patient stops seizing, generally in 6 weeks, and repeat the DWI. So if the patient is not seizing, the DWI should return to normal. So unlike stroke, in which you will see some volume loss, some encephalomalacia, and other things, seizure-related excitotoxic injury is reversible in majority of the cases. So you will see complete normal DWI on follow-up. So even if you don't have ASL, you can still make a diagnosis of seizure. Okay, and this is PRESS. PRESS can also show diffusion and then increased ASL. I won't go into much of details here. All right, so vessel wall imaging is another thing which we do at our hospitals and which is slowly spreading around the world. And it is an emerging technique for evaluation of what is causing the vessel narrowing. I'll just show a few pictures of this. So this patient had right MCA wall enhancement associated with narrowing, and this was a patient with vasculitis. So whenever we get a young patient with a stroke, we generally get a vessel wall imaging because we want to see whether there is any enhancement on the wall or not. And then this patient had a little bit of enhancement, but was reversible. And this patient was had reversible vasoconstriction syndrome. So vessel wall imaging is also a very good tool and can be added to the protocols, but that would require contrast. Okay, so now moving on to, am I sure this is not a stroke mimic? And it's important to know that all diffusion restriction is not a stroke, and we can be really helpful to the clinicians in making a better diagnosis and suggesting that this is not a stroke. So there are multiple other etiologies which can cause diffusion restriction: tumor, seizures, demyelinating disease, METs, infection, DGA, fat emboli. So first of all, tumor. So primary brain neoplasm can be confused with strokes. And it's important to know that tumors are more mask-like and expansile, and MR perfusion and spectroscopy can be helpful. But even if you don't have spectroscopy and perfusion, it's important to follow up to see if it is like an infarct in which there is volume loss, or it's actually like a tumor which is spreading. And it's important to know tumors can present like stroke. So a patient with GBM can have sudden onset of right-sided or left-sided weakness. So it's an important differential to keep in mind. So for example, this patient, it almost looked like this patient had, a hyperdense MCA, but you can see how expansile this looks. This is too much for infarct. There's too much of swelling here. So we thought we need to get an MRI because this doesn't look like stroke to us, so the history was stroke. And here On the T2, you can see how there's expansile signal abnormality in the temporal lobe and in the insula. And on the spectroscopy, there was a choline peak. So this was tumor. So it's important to think whenever you see, expansile signal abnormality, to get either an MR, and if not, just a follow-up to see how this evolves. We talk about seizures. Seizure can cause diffusion signal abnormality in all these areas. And it's important to know, it's a very important stroke mimic, because we see strokes in inpatients who are admitted to the hospital, and many times they're seizing. So that will cause diffusion abnormality. So seizures will lead to diffusion abnormality in hippocampus, pulvinar of the thalamus, the cortical regions, and the contralateral cerebral hemisphere, as well as the splenium. The seizure-related excitotoxic injury is confined to the cortex and does not involve the subcortical white matter as much as infarct does. But if you see diffusion in these areas, always take a pause and think, am I dealing with a seizure patient or am I dealing with a stroke patient? So I think I showed you the diffusion restriction in the hippocampus in seizures. And the important thing is, if you're not sure, just get a follow-up. And if it resolves completely with no flare, with no diffusion, it's generally a seizure. This is a very nice entity, which is really good for radiologists to know, because it's very classic. It's one of the board questions which we test here in US. But it's so classic because patient presents with sudden onset of profound antegrade amnesia, which goes away within 24 hours. And on MR, we see punctate hyperintense focus of restricted diffusion in the lateral aspect of the hippocampus. So right here, we see a focus of restricted diffusion in the lateral aspect of the hippocampus. So this is a patient of transient global amnesia. So if the patient has transient memory loss and has just this finding in the brain, a tiny focus of restricted diffusion in the lateral aspect of the hippocampus, you know this is a patient of TGA and not a stroke. Okay, multiple sclerosis is also an important stroke mimic. You'll see multiple white matter changes. The important thing is it can have peripheral restricted diffusion with central increased ADC, and it can have an enhancing rim. Again, follow-up is the best way to look at that. So here's a patient with multiple sclerosis. We can see the peripheral diffusion restriction right here. You can see the rim of diffusion restriction, and you can see that there is post-contrast enhancement. And the important thing about multiple sclerosis is sometimes it's so classic because you can see the white matter lesions are actually converging centrally towards the corpus callosum. So this is more like an MS picture rather than multiple tiny infarcts. All right, metastatic disease can look like stroke. And the things which would favor a metastatic disease is a lot of eosinophilic edema surrounding the lesions. If there are additional sites of disease like skull mets, and if there are absence of large infarcts. So this patient had flare signal abnormality, multiple foci of diffusion restriction, and multiple foci of enhancement. So again, and this patient also had a lung mass. So it was metastatic disease rather than embolic infarcts. This is again a classic entity. If you know it once, you'll remember it forever. So this is fat emboli. So after a long bone fracture or orthopedic procedure, if you see innumerable punctate foci of restricted diffusion with microhemorrhages, let me show it to you. It's very classic. So if you look at this is a susceptibility and this is diffusion. If you see numerous foci of restricted diffusion and numerous foci of susceptibility throughout the brain, fat emboli is a diagnosis. All right, so just moving on with the stroke algorithm. The first step is always the non-contrast CT. The second step is CT angiogram. And the third step is, depending on the availability, an MRI or a CT or MR perfusion. What is in the horizon for stroke imaging? Machine learning has been used for stroke. We talked about the late acute ischemic stroke, in which the patients can be treated for up to 24 hours. The CT scanners and ambulances, and virtual reality. So this is these are some future advances coming up in stroke. And there's a very good paper which we have researchers at University of California, San Francisco, and we also had researchers from MGH which summarizes everything which is going on in the stroke world. And then this is just a summary of how artificial intelligence has been used in stroke for automatic detection, in diagnostic imaging and for other things. I won't go into too much of detail here, but I just put it out there so that You guys know that nowadays machine learning and artificial intelligence is becoming very important in radiology, and for automatic volumetric assessment of the stroke, for automatic detection of proximal vessel occlusion. So, you know, especially in the areas where we do not have a radiologist, whether we can just install a software which will automatically detect a stroke or detect a proximal vessel occlusion. This is an example of CT scanner in ambulance, just because people want to diagnose as early as they can. And we have some centers in US who do that, who have a CT scanner in the ambulance. Again, we are moving from time of the philosophy that time is brain to physiology is brain, which is very interesting. So it is possible that a patient who is 24 hours post-symptom onset can still get treatment because they do not have a large infarct. And that is where the future lies of radiologists helping out how big is the infarct and where the patient can get still treatment even if they are much later in the journey in stroke. All right, so let me just end with this case. This is a 61-year-old with onset of symptoms, which was 12 hours. I came to the hospital 12 hours after symptom onset. Then I had stroke scale was 16. So we saw this hypodensity in the MCA. We confirmed that on the CT angiogram. And again, this is a distal M1. The vessel hasn't turned yet. Distal M1 clot. On the perfusion, we saw a large defect on MTT, and the CBV was relatively normal. So we see a mismatch here. The CBV is normal and the MTT has a large defect. So we know that there's viable tissue. This is the angiogram. It showed the M2 clot right here in the superior division. Then neurointerventionalists went after that and cleaned it up, and the vessel is open now. And the patient did so well. The NIH stroke scale was 2 at discharge. All right, thank you very much.